Welcome to the FRAT training module, Basics of Hereditary Ovarian Cancer Diagnosis and Treatment. I'm Sue Friedman, founder and executive director of FORCE. Before we get started, I'd like to share some basic tips to help make your viewing enjoyable. If you place your cursor at the bottom of the screen near the Volunteer Force Academy logo, this image will pop up and will enable you to pause, rewind, fast forward, or play. You can also change the volume or make the screen larger by clicking here. So if you need to take a break or go back over a section, feel free to use this tool to do so. Just a quick note about FORCE and our programs. Our organization has 4 key pillars upon which all our programs are based. We have our support programs, which include our in-person outreach groups and our peer navigation program, among others. Our education programs, which include our conference, our website content, and our X-ray program. Advocacy and policy efforts, and then research, which includes research recruitment, the About Patient-Powered Research Network, and our research advocacy training, which encompasses this program, FORCE's Research Advocate Training Program, or FRAT for short. So how will FORCE help you as a FRAT graduate? We'll provide the training to prepare you to serve a role in research advocacy and help you gain an understanding of how you can be effective in providing input to guide the research process. We'll connect you with research advocacy opportunities. We'll provide resources to aid you in preparing for and securing advocate positions, such as helping you with applications and your biosketch and providing a letter of cooperation. And we'll follow up with you after the activity to see how it went. We'll also stay in touch with you through a quarterly FRAT newsletter, which includes information about current placement opportunities, scholarship opportunities to national conferences, educational opportunities, and others. And now it's my honor to introduce our speaker, Dr. Douglas Levine. Dr. Levine received his medical degree from Mount Sinai School of Medicine and completed his residency at Mount Sinai Medical Center and a fellowship at Memorial Sloan Kettering. Dr. Levine is the director of the Division of Gynecologic Oncology at the NYU Perlmutter Cancer Center. In addition to caring for patients with or at high risk for gynecologic cancer, Dr. Levine is the current head of the Gynecologic Research Laboratory, where he studies cancer prevention, precision medicine, and rare tumors with unmet needs. Dr. Levine has received research funding from the National Cancer Institute, the Department of Defense, Stand Up to Cancer, and the Gynecologic Oncology Group. He has received many distinctions and awards and sits on the Scientific Advisory Committee of the Ovarian Cancer Research Fund Alliance, the Clarity Foundation, the Honorable Tina Brosman Foundation, and FORCE. So please welcome Dr. Douglas Levine.
Thank you, Sue. Today we're going to talk about the basics of hereditary ovarian cancer diagnosis and treatment. The outline will include types of ovarian cancer with a focus of epithelial biology, gene mutations associated with ovarian cancers, how ovarian cancer is diagnosed and staged, how it's treated initially, and treatment options for recurrent ovarian cancer, maintenance therapy, and the role of PARP inhibitors. So the ovary contains many types of cells, and this leads to different types of cancers. The most common type of ovarian cancer is called epithelial ovarian cancer, and depicted on the left is a picture of epithelial ovarian cancer coming from the surface of the ovary, which we'll talk about in a few minutes and dispel that myth. Other types of cancers include sex cord stromal tumors that come from the substance of the ovary and the maturing follicles, as well as germ cell ovarian cancer, which comes from the germ cells. On the right side, you can see a stromal cell with various layers, including granulosa cells and thecal cells, which can lead to various types of sex cord stromal tumors. And these can affect younger women and are much more favorable, and we will not be speaking about them too much more today. On the next slide, you'll see another depiction of the types of ovarian cancers and where they can come from, with just a little more detail showing that epithelial cancers account for 90% of malignant ovarian cancers, and germ cell cancers and stromal cell cancers are much less common. Now, on the next slide is some remarkable information that we learned about 5 to 10 years ago as we started to do risk-reducing surgical procedures. Every so often, we would find a cancer that was really detected by accident. But the fascinating thing is that in these cancers, most of the time, they were actually found at the end of the fallopian tube and not on the surface of the ovary itself. And so that led us to believe nowadays something that I'm not going to talk about too much in this presentation, but that most ovarian cancers, in particular high-grade serous ovarian cancers, likely originate at the end of the fallopian tube, and then they fall on top of the ovary and they grow on the ovary, so they look like ovarian cancers, but they actually begin at the end of the fallopian tube. And that's for high-grade serous ovarian cancer, which is the most common type of ovarian cancer and also the most aggressive. Other types of ovarian cancers include endometrioid ovarian cancer and clear cell ovarian cancer, and they grow out of something called endometriosis, which is when glands from the inside of the uterus can implant in the pelvis or on the ovary. And so we call these endometriosis-associated ovarian cancers. Those are also common types of ovarian cancer. And the message from this slide, as it says, is that many ovarian cancers, although they occupy the ovary, they do not actually originate in the ovary. And you can imagine a topic for a different day is that there's lots of prevention opportunities now that we know that many ovarian cancers may originate at the end of the fallopian tube. Next slide. So just as some background, you can develop mutations from two main ways. So some mutations are inherited from your parents, and those would occupy every cell of your body, and those are called germline mutations, such as BRCA1 and BRCA2 mutations, which are very commonly inherited from parents, and they're in every cell of your body, are germline mutations. And then some mutations will develop only within a cancer or within a specific part of the body, and since we're talking about ovarian cancer, we'll say ovarian cancer, and those somatic mutations are not inherited, and some BRCA1 and BRCA2 mutations also can be somatic and can develop within the tumor. And so those are the two types of mutations: germline mutations, which are inherited and are in every cell of your body, and somatic mutations, which are just in a specific cancer type. So as well as this overview here, we also want to mention that ovarian cancers are not one disease. We talked about the fact that they can originate from different parts of the body, but they also look different under the microscope. And here on this slide, you can see that high-grade serous carcinoma is the most common type. And again, endometrioid and clear cell cancers are the next most common types that we talked about. Other types of ovarian cancer are carcinosarcomas, which are fairly aggressive, low-grade serous carcinomas, which are not as aggressive, but still can be troublesome, and then mucinous ovarian cancers, which are quite rare, as well as other rare subtypes of ovarian cancer. And if we advance just a little bit more, we'll see that on the right side of this slide, we have a depiction of common events that occur in ovarian cancer. And as you may be aware, there's BRCA mutations that can be found in about 20% or possibly 25% of ovarian cancers. And again, 2/3 of these are inherited, called germline mutations, and 1/3 or 1/4 are somatic mutations. Other mutations that we commonly see are mutations in other genes that affect DNA repair. We also can see silencing of the BRCA1 gene through something called promoter methylation, where the gene can be turned off. And the other point of this pie chart on the right is that about half of the defects will result in the tumor having trouble repairing the DNA. And as you'll see later on in the talk, those types of tumors that have trouble with DNA repair are called homologous recombination deficiency, or HRD, are tumors that are keenly sensitive to treatment with something called PARP inhibitors that we'll talk about again in a few minutes. So on the next slide, you'll see that there are also other mutations that are associated with DNA repair. This is a paper from a few years ago. And again, you can see when you look at a whole compendium of various genes that can affect DNA repair, about 25% of cases of ovarian cancers may carry an inherited mutation, and about a little less than 10% may have a somatic mutation. On panels B and C, you can see that there's a number of genes that are thought to impair DNA. Now, all of these genes have not been proven to actually increase the risk of ovarian cancer. That takes a lot of additional studies to really prove that finding. For example, in the middle panel, you'll see genes like RAD51C and D, which are now pretty well defined to be risk genes for developing ovarian cancer. Some of the other genes seen here are risk genes, and some are just thought to be risk genes, but there's not enough evidence to suggest they actually increase the risk of ovarian cancer as of now. And so this makes genetic testing very complicated to interpret, which is why the availability of genetic counselors is very useful, so that genetic testing reports can be interpreted properly. And on the next slide, you'll also see that within tumors, you'll find various genes that are commonly mutated. P53 is referred to as the caretaker of the genome. It affects many things, including how the cells replicate their own DNA material, and almost all high-grade serous ovarian cancers will have a mutation in P53. And there's some similarities between high-grade serous ovarian cancer and high-grade serous endometrial cancer and basal-like breast cancer. They all have P53 mutations. They all have amplification of genes called cyclin E1 and MYC, and amplification means that there's too many copies of a specific gene, and some other genes in serous ovarian cancer like BRCA1 and 2 can be frequently mutated. If we keep moving along here on the following slide, I'm going to get into a little bit about the stages of ovarian cancer. So one of the first things we do when we find someone who might have ovarian cancer is we want to determine, has the cancer spread beyond the ovaries or the pelvis. So if there's no evidence that the cancer has spread anywhere, we want to perform a staging procedure, which we'll talk about in a few minutes, to see if the cancer has spread anywhere. But basically, the simple definition of the stages is stage 1 is when ovarian cancer is confined to the ovaries. Stage 2 is when it's spread to other parts of the pelvis. Stage 3 is when it's spread to other parts of the abdomen, and stage 4 is when it's spread beyond the abdomen into the chest or other anatomic regions. Because it's so difficult to diagnose ovarian cancer at an early stage, most ovarian cancers are diagnosed at stage 3 or stage 3C, which is when cancer is spread to other parts of the abdomen and peritoneum, and it's visible to the naked eye. On the next slide, you can see more specifics about the staging. There are many sub-stages, which I won't go through today. If you're interested in reading about the stages, this can be found online, or you can pause the webinar and spend some time reviewing all the sub-stages that are shown here. Next slide, please. So the way we diagnose ovarian cancer is through a combination of symptoms, tumor markers, and imaging. On the top left is a picture of the molecule called CA125. It's a tumor marker that is expressed in most ovarian cancers, particularly high-grade serous ovarian cancer, and we can measure the level of this tumor marker with a simple blood test. And if this tumor marker is quite high, that is suspicious for ovarian cancer. I'll just mention that the tumor marker is not a good way to screen for ovarian cancer. There's been a lot of studies trying to look at CA125 levels as a screening test, and so far they have not been shown to be effective. On the bottom part of the slide, you can see a CT scan, and the arrow is pointing actually to directly to a muscle in the abdominal wall, but just past that muscle with the arrow, if it was extended just a little bit into the peritoneum, you would see a tumor mass, which is in the right side of someone's abdomen, and this to an oncologist would clearly look like ovarian cancer coupled with an elevated CA-125. And so this would be very suspicious for a newly diagnosed ovarian cancer patient. And on the right side is a number of symptoms that women will often report when they have ovarian cancer. The difficulty is whether these are symptoms of early ovarian cancer or advanced ovarian cancer. In retrospect, many women who do have early ovarian cancer have these symptoms, but these symptoms also can sometimes be nonspecific. And so differentiating these symptoms for other things that can happen and ovarian cancer can be very tricky. So I usually recommend to my patients that anyone who has some of these symptoms that are persistent, and in my mind that means 2 weeks or more, and they're getting worse and they're unusual for an individual person, that might be a reason to report that to a healthcare provider. Next slide, please. So all of our professional organizations recommend that if someone is thought to have ovarian cancer, they're treated by a gynecologic oncologist. This is a doctor who specializes in treating ovarian cancer and other gynecologic tumors. And a number of studies have shown that patients have better outcomes as measured by better surgery and better overall and long-term survival when they're treated by a gynecologic oncologist. And so we strongly recommend that if someone thinks they might have ovarian cancer, they ask their referring doctor to send them to be evaluated by a gynecologic oncologist. And the other important message I would say is that if you think you have some of these symptoms that are unusual, and though they can be symptoms of other gastrointestinal conditions and other common gynecologic conditions, it's important to ask a doctor, do you think these could be symptoms of ovarian cancer? Because ovarian cancer is a rare tumor, and by patients and doctors partnering together, we can try to make sure we diagnose ovarian cancer in a timely fashion. Next slide, please. The complete surgical staging for cancer that's presumed to be confined to the ovary or the pelvis is to make sure that we can determine if it's spread to any other areas, because that affects not only the outcome, but it also affects the treatments that we give in some situations. And so as part of a surgical staging procedure, we evaluate the pelvis to see if there's any disease that can be detectable outside of the ovaries. We also do random biopsies. We inspect all abdominal surfaces. We remove something called the omentum, which is a fatty portion of tissue that comes off of the colon or the intestine. And we also sample lymph nodes in the pelvis and the abdominal area called aortic lymph nodes to see if the tumor has spread to any lymph nodes. And doing a hysterectomy to remove the uterus and the cervix is also part of the surgical staging procedure. Once we do this procedure, we can assign a surgical stage, which you can see on the right side of this slide, which is typically 1, 2, 3, or 4. And as I mentioned, stage 3 is the most common type at which ovarian cancer is diagnosed. But the take-home message is that when ovarian cancer is diagnosed at stage 1, it does have quite a good outcome. And so one of our research goals is to move advanced stage cancers over to earlier stage cancers. Next slide. So if we're clearly aware that cancer has spread beyond the ovary, we then perform something called cytoreductive surgery, which is also called debulking surgery. And so if we can see the cancer with the naked eye, the goal of the procedure is to remove as much cancer as possible, with the goal of removing all cancer that we can see with the naked eye. And so that is a cytoreductive procedure, and we basically go where the cancer goes, and we use a number of different surgical techniques, including sometimes resecting a portion of the bowel or taking out other organs such as the spleen, or taking out portions of the diaphragm as needed, with the real goal of taking out all visible cancer, because this has routinely been shown to be associated with the best outcomes. Next slide. So here is a depiction of the standard treatment of advanced ovarian cancer. It starts with surgical cytoreduction, followed by chemotherapy, often given intravenously and sometimes given directly into the peritoneal cavity with intraperitoneal chemotherapy, and then a period of remission follows with observation, and a portion of patients will be cured, and some patients will have recurrent disease and then receive subsequent surgery or subsequent chemotherapy. The treatment for recurrent cancer is highly individualized, and it really depends on when and where the cancer does return. Next slide. So one of the ongoing controversies we have in our field right now is whether surgery should be the initial treatment for ovarian cancer, which often can be a large and aggressive and long operation, or should chemotherapy be given first to shrink the cancer. And I would say most practitioners and gynecologic oncologists have very strong opinions as to which is the preferred approach. On the next slide, you'll see a number of studies that have been conducted comparing initial surgery called primary debulking surgery, or PDS, with initial chemotherapy called neoadjuvant chemotherapy. And you can see that in some of the studies shown in the first 2 columns or 4 columns, the EORTC study and the CHORUS study, there was no difference in overall survival between these 2 approaches. But in both studies, the overall survival was much worse than in some of our American randomized studies of various chemotherapy regimens, the GOG studies, which you can see on the right side of the slide. And you can see the overall survival is really 50 to 100% better than in the neoadjuvant studies. And this is probably due to some bias in the studies and some selection for patients who may be have less favorable features for having a good outcome. And the bottom line is that surgery is generally superior to neoadjuvant chemotherapy and remains the standard of care, but there'll always be a subset of patients who cannot have a large surgical procedure, either because they have medical conditions that do not allow them to tolerate a long surgical operation, or they have disease in certain areas like the chest and other areas that just can't be removed. And in those situations, we have to begin with surgery because the goal of surgery, again, is to remove all disease. And if we can't get to the disease or can't remove it, then we have to give chemotherapy first. On the next slide, you'll see that one of the reasons why chemotherapy first may not be such a good option if it can be avoidable is because when you treat a large population of cancer cells with chemotherapy, you're more likely to induce resistance than if most of the cancer has been removed with surgery, and then you do give the chemotherapy afterwards. Next slide. So nowadays, we have many options for how we can treat patients after surgical resection. And there's even new studies that have just come out last week that makes some of the initial treatment even more complicated. And so we have lots of options, and I will not tell you which is the best option because this is clearly a moving target, and there's clearly some controversy among well-qualified gynecologic oncologists. But some of the options that have shown benefit and that many people use on a regular basis include giving chemotherapy directly into the belly, which is called intraperitoneal chemotherapy, and that's been shown to be very effective. Giving chemotherapy more frequently with something called dose-dense chemotherapy, where we give one of the drugs on a weekly basis. That has been shown to be very effective in some studies. Giving a drug called bevacizumab, which targets blood vessels, has also been shown to be effective in some studies. And then we have other studies that sort of show the opposite. And some preliminary data about the weekly therapy has shown that it's actually not as effective as we first thought that it was. And so this is clearly a moving target, but I would say the bottom line is that we have many effective therapies. They all work quite well to treat initial cancer, and many patients will go into remission. In fact, most patients will go into remission after initial therapy. And what the actual best treatment is for a specific person must be individualized based on the available data, which is why you want to see someone who is following the latest research, and why research is so important, because it shapes our knowledge as to what the best treatments are for people with ovarian cancer. Next slide. So a typical course for a woman with ovarian cancer is they'll have primary treatment and then go into remission, and a portion of those patients will be cured and their cancer will never ever come back. But more commonly, the cancer will come back, and if it comes back after a short period of time, we call that platinum-resistant disease, because we know that those cancers do not respond quite as well to retreatment with platinum-based chemotherapy. And if the cancer comes back after a longer period of time, we call that platinum-sensitive disease, because the cancer is more likely to respond to platinum treatment a second time. After giving treatment for a first recurrence, many patients will go back into a clinical remission where there's no evidence of disease, but then uniformly the cancer will come back in the future, and then we'll go on with a series of treatments and responses, and many patients will receive many different types of treatment as we figure out which is the best treatment for a specific person. But after a number of treatments, the cancer becomes increasingly resistant, and then typically after a number of treatments, the tumor will develop what's called platinum resistance and become harder to treat with our standard agents, which is why we're using new investigational agents to overcome this type of resistance. And we do have a lot of promise that our treatments nowadays and the new drugs that are being developed in clinical trials will be effective. If we go to the next slide, when cancer does come back, sometimes we will be able to operate again and remove all the cancer, and this is also thought to be effective. And as I mentioned before, this will happen based on when the cancer comes back and where it comes back. And if it comes back at only one or a few sites and we can take out all the cancer and the disease has been away for a long time, that would be recommended. Next slide. So there's many different treatment options for women with recurrent ovarian cancer. This is a page from the National Comprehensive Cancer Network guidelines, and this is only one of 2 pages that show a number of options for recurrent ovarian cancer. And basically, as you can see, we have a lot of drugs, all of which have shown activity, and every day we're making new discoveries. And on the right side of this table, you can see all the PARP inhibitors, which really have revolutionized the way we're treating ovarian cancer nowadays. Next slide. There's a concept called maintenance therapy, and what maintenance therapy is basically is after someone's responded to standard treatment and the cancer has gone into remission or has had a very good response, can we give a second drug that really keeps the cancer under control rather than treating cancer that's actively growing? And again, a lot of drugs have been tested with maintenance therapy. First, we tested something called paclitaxel, which is actually a standard chemotherapy agent. And the idea was if we gave more of it, maybe it would work better. And that wasn't overwhelmingly positive. Some drugs that target blood vessel formation, including angiogenic inhibitors, those are effective, and if you take the drug long enough, there will be some benefits, and it's a difficult question as to whether the benefits outweigh the risks of taking the drugs for many months. And now we have studies of PARP inhibitors, where particularly in patients with BRCA 1 and 2 mutations, the PARP inhibitors work very well to keep the cancer away for as long as possible. On the other hand, they also work quite well to treat cancers when they do come back. And so now we have a bit of a conundrum as to when actually to give the PARP inhibitors. Next slide. So the reason we're excited about PARP inhibitors, particularly in women who have BRCA1 and BRCA2 mutations, is we know that the BRCA mutations make it difficult for the cancer cells to use a particular type of DNA repair to repair the damage caused by chemotherapy. However, when we give a PARP inhibitor, that also affects other ways the cancer cells can repair DNA. If we give this to someone who already has a defect in the BRCA1 and 2 proteins, now the cancer cells are overwhelmed, and giving a PARP inhibitor to a BRCA-associated tumor cell will allow the tumor cell to completely die and not be able to repair its DNA, and that's why the PARP inhibitors are very effective in women who have BRCA1 and 2 mutations. And the bottom part of this slide just shows the dramatic responses that were identified in the early studies from more than 5 years ago, when women with BRCA mutations and some who did not have BRCA mutations were treated with PARP inhibitors. Next slide, please. So when we use PARP inhibitors for treatment of active cancer, as is shown here, we notice that women who have BRCA mutations respond very well, as I mentioned. We also can find tumors that have a defect in DNA repair called homologous recombination deficiency, but they don't have an identifiable mutation in BRCA1 and 2. And these patients will respond to PARP inhibitors not quite as well as those who have BRCA mutations, but better than tumors that don't have any defects in DNA repair. And so it's sort of an intermediate group that does benefit from PARP inhibitors when treating active disease. On the following slide, you'll see some results from maintenance studies where, again, there's a lot of data on this slide, but the bottom line is when we give PARP inhibitors as maintenance therapy to someone who's either in remission or who has responded well to a prior therapy, the PARP inhibitors also work. Again, they work best with women who have BRCA mutations. They work quite well as also in tumors that have deficiency in DNA repair. And they do work in a statistical manner, but with a much more modest benefit to tumors that have no defects in DNA repair. Now, the next slide, we can quantify that, and you can see all of the PARP inhibitors that have been tested in the maintenance setting. Niraparib and olaparib are now FDA approved, and most likely rucaparib will become FDA approved at some point in the probably not too distant future. And you can see these studies are each done a little bit differently, and some of the studies just test germline BRCA mutations, and some test all BRCA mutations, and some test subsets that have defects in DNA repair. But this table basically reflects the data on the previous slide, showing again that the best responses are seen in women who have BRCA mutations that are either inherited or specific to the tumor. And just to conclude, on the following slide, just some concluding remarks that we can prevent ovarian cancer in most women who have inherited BRCA1 or BRCA2 mutations. We cannot effectively screen for ovarian cancer today, and therefore we recommend against ovarian cancer screening for women who are at average risk, and this is clearly different from the high-risk population, mostly defined by mutations in BRCA1 and 2. We are working very hard to develop new approaches for early detection, particularly because we now believe that most ovarian cancers originate from the end of the fallopian tube, and clinical trials are actually open. The WISP study is testing the removal of the fallopian tubes in women who have declined to have the ovaries removed, and we have a clinical trial now open at many sites across the country that can be identified with the clinical trial number listed on this slide. As far as treatment, ovarian cancer treatment is very effective and well tolerated for most women. Some women with ovarian cancer can be cured. Some cancers will come back, and that's where clinical trials can often be the best medical treatment. And PARP inhibitors are readily available for women with BRCA-associated cancers. How best to apply them is not entirely clear, whether maintenance setting or active treatment, but it is very exciting that we have a whole class of drugs that work very well to treat ovarian cancers that are BRCA associated, and also many other ovarian cancers. And by designing and conducting intelligent clinical trials, we can discover predictive biomarkers for various targeted therapies. I appreciate the opportunity to discuss these issues with you today, and I'll now turn the webinar back over to Sue.
Thank you so much. That was outstanding. We really appreciate it, Dr. Levine. And I want to thank everybody for their attention to this webinar. Thank you so much for being a volunteer for FORCE. You're really helping us make a difference for people affected by hereditary breast, ovarian, and related cancers. Take care. Thank you.